Starting in December 2019, the novel coronavirus SARS-CoV-2 has resulted in a global outbreak of the lung illness COVID-19. This respiratory illness ranges from mild self-limiting respiratory condition to severe viral pneumonia that can lead to multi-organ failure and death. The number of cases has exploded recently in the United States, European countries, and also throughout the world. As of this recording, there are over 350,000 confirmed cases and over 15,000 deaths globally. There are currently no approved treatments or vaccines for diseases caused by coronaviruses. Social distancing is becoming the mainstream approach to control the spread of the infection. However, several small trials and case reports indicate the potential efficacy of several drugs used for other diseases. Additionally, several companies in the United States and Europe are in process of developing a vaccine. COVID-19 is a novel pneumonia that's caused by the novel coronavirus SARS-CoV-2. SARS-CoV-2 is the seventh coronavirus that is known to infect humans. SARS-CoV-2, along with two other coronaviruses, SARS-CoV and MERS-CoV, can cause severe disease that involves the lung and may cause multi-organ failure and death. The early causes of COVID-19 appeared in the Hunan market in Wuhan, China. Because of the similarity of SARS-CoV-2 with SARS-CoV-like coronaviruses, it is likely that bats serve as a reservoir host. Genetic analysis suggests that SARS-CoV-2 underwent natural selection in an intermediate that could be a pangolin, which is a type of scaly anteater, which has coronaviruses with strong similarity to SARS-CoV-2. Additional genetic selection took place in humans, which then led to the genetic features that enabled this global pandemic. Coronaviruses are diverse, enveloped, positive sense, single-stranded RNA viruses. They can cause respiratory, enteric, and neurological infections. They have common genetic features including the surface structural spike glycoprotein S, which is of high interest for the development of novel therapeutic strategies. The S protein is cleaved by the endosomal acid proteases cathepsin L to activate its fusion activity. Angiotensin-converting enzyme 2 serves as a key receptor for the viral attachment and is key in determining its viral pathogenicity. The virus enters the cells through the endosomal pathway and then disassembles and releases the viral RNA into the cytoplasm. Following translation, replication, and RNA synthesis, the viral structural proteins are translated and inserted into the endoplasmic reticulum, where virion particles are assembled. Following assembly, the viral particles are transported and released by exocytosis. With the widespread of COVID-19 throughout the world and the range of disease severity, there's a need for a global approach to stage the progression of COVID-19 and develop a personalized therapeutic plan to treat patients. Although there are no approved medications for COVID-19, several therapies have emerged as promising treatments. Physicians around the world have reported on the use of several experimental and investigational strategies. Based on data from the Chinese Centers for Disease Control and Prevention, 81% of patients present with mild symptoms. About 5% of patients present with respiratory failure, septic shock, and multi-organ failure. To guide therapeutic and possibly life-saving measures, Siddiqui and Mehrer propose to classify COVID-19 into 3 stages. Stage 1. During this stage, SARS-CoV-2 interacts with ACE2 receptors that are abundant in the human lung and intestine. Patients typically present with mild symptoms. Stage 2A, the virus multiplies, causing localized pulmonary inflammation. The patients may develop viral pneumonia with cough and fever. Stage 2B, in the later phases of Stage 2, patients will experience hypoxia and will need mechanical ventilation. Stage 3, patients with severe COVID-19 progress to Stage 3, which involves hyperinflammatory response. In this phase, markers of inflammation are elevated. In stage 1, patients can be treated by managing symptoms. The availability of effective antiviral agents could prevent the progression and minimize contagiousness and facilitate recovery. In stage 2A and 2B, patients might require hospitalization to manage symptoms. Antiviral therapy could prevent progression and facilitate recovery. Patients with hypoxia will need mechanical ventilation support and oxygen treatment. In stage 3, patients can benefit from immunomodulatory agents such as IL-6R targeted monoclonal antibodies such as tocilizumab. These drugs could reduce the hyperinflammatory condition and reduce lung damage caused by excessive immune response. With the pressing need for immediate drugs, a fast drug discovery strategy must be adopted. In addition to the immediate identification of promising therapies, a traditional drug discovery strategy should be initiated for the long-term discovery of targeted therapies. In a time of global health emergency, identifying effective therapies within a short period of time is a pressing need. Drug repurposing as a strategy to discover and develop drugs emerges as an important approach. The main advantage of this strategy is that the safety of the repurposed drugs are already available, which significantly reduces the risk of failure due to toxicity. The time needed to develop a therapeutic is also significantly shorter, as there is no need to perform early-stage evaluation and tests. Additionally, depending on the stage of the drug of interest, the costs for development could be significantly lower. Based on the evolving understanding of the pathology and progression of COVID-19, investigational viral-targeted agents can be beneficial to COVID-19 patients. These drugs could be used prophylactically to reduce the incidence of infection among individuals who are exposed to the virus. Also, they can be used to treat patients potentially with different COVID severity levels to facilitate recovery, reduce contagiousness, and prevent the progression of the disease and associated mortality. Patients with advanced stage 3 disease would benefit possibly from immunomodulatory drugs that could suppress the hyperinflammatory condition that results in mortality. With the evolving understanding of the pathology of COVID-19, emerging data indicate that in the late advanced stages of the disease, hyperinflammation is a major cause of tissue destruction and death. The discovery of drugs that could effectively suppress the hyperinflammatory condition could save lives and change the course of the disease. Next, we'll cover virus-targeted agents. Previous studies suggest that lopinavir-ritonavir, which is known as Kaletra, is effective for the treatment of MERS and SARS. Additionally, case studies suggest that combining lopinavir-ritonavir with interferon beta-1b showed efficacy in viral clearance in patients with MERS. The LOTUS trial in China, which LOTUS stands for Lopinavir Trial for Suppression of SARS-CoV-2, is a randomized controlled open-label clinical trial to evaluate the safety and efficacy of lopinavir-ritonavir for the treatment of patients with COVID-19. A key advantage of pursuing this drug is its wide availability and the emerging case reports that suggest it may be useful. This trial was started on January 18, 2020, only 1 week after the identification and sequencing of SARS-CoV-2. This trial represents a heroic effort by the research group as they succeeded in enrolling a large number of eligible patients, nearly 200, in the middle of the emergent outbreak. In the LOTUS trial, 199 patients with laboratory-confirmed SARS-CoV-2 infection were randomized. 99 were assigned to the lopinavir-ritonavir group. They received 400 milligrams, 100 milligrams orally twice daily, and 100 patients were randomized to the standard care group. Standard care measures included supplemental oxygen, non-invasive and invasive ventilation, antibiotic agents, vasopressor support, renal replacement therapy, and extracorporeal membrane oxygenation. Both study arms had patients with heterogeneous disease, and the patients received several additional treatments, including interferon 11% and glucocorticoids 34%. Unfortunately, lopinavir-ritonavir treatment did not result in significant improvement in time to clinical improvement in the intent-to-treat population compared with the standard of care. About 14% of patients in the lopinavir-ritonavir group had to discontinue the treatment due to gastrointestinal adverse events. Another agent being explored for COVID-19 is favipiravir, and this is a broad-spectrum antiviral agent that's approved for the treatment of influenza in Japan. It is effective against a wide variety of RNA viruses. When activated inside the cell, it inhibits RNA polymerase and suppresses RNA synthesis. Favipiravir was discovered by high-throughput screening of a chemical library for antiviral activity against the influenza virus. It undergoes intracellular activation by phosphoribosylation to its active form favipiravir RTP, which is ribofuranosyl 5B triphosphate. The active metabolite is recognized as a substrate by the RNA polymerase, resulting in inhibition of the RNA polymerase activity. The broad-spectrum activity of favipiravir is due to the conserved catalytic domain of the RNA polymerase among RNA viruses. In this open-label control study, the favipiravir group included patients with laboratory-confirmed COVID-19 who received oral, and I'm going to call it FPV, on day 1, 1,600 milligrams twice daily. Then days 2 to 14, they received 600 milligrams twice daily with interferon alpha by aerosol inhalation, 5 million units twice daily. The control group included patients who were treated with lopinavir-ritonavir, and that was given on days 1 through 14 at 400 milligrams, 100 milligrams twice daily, plus interferon alpha by aerosol inhalation, 5 million units twice daily. Patients in the favipiravir group had a shorter viral clearance time in comparison with the control arm, which was 4 days versus 11 days, and that's significant at the level of P is less than 0.001. The favipiravir group also had significant improvement in chest imaging compared with the control arm. The improvement rate was 91.43% versus 62.22%, with a p-value of less than 0.004. In a 56-year-old female patient with COVID-19 from the favipiravir group, they did a score of chest CT scan and showed that parts of the CT images obtained before beginning the favipiravir treatment was scored as 15, according to the scoring method, and then in panels D through F, they show parts of the CT images obtained on day 12 after favipiravir treatment, and those were scored at 6. The median time of viral clearance for the patients treated with favipiravir was estimated to be about 4 days, which was significantly shorter than the time for patients in the control group who had a viral clearance time of 11 days, and that was significant at P is less than 0.001. Large-scale clinical trials are needed to confirm the findings of this small study. While the findings show promise for favipiravir, large-scale clinical trials are needed to confirm the findings of this small study. Remdesivir, also known as GS5734, is a phosphoramidate prodrug of an adenosine C nucleoside. It was developed by Gilead Science Inc., however it's not licensed or approved anywhere for any specific indication. It's recommended for the treatment of cats with feline infectious peritonitis, which is uncommon but fatal and is caused by a feline coronavirus. It competes with adenosine triphosphate and acts as a delayed RNA chain terminator against the Ebola virus, which suppresses RNA synthesis. Recent clinical trials indicate that its use for Ebola virus disease results in a higher mortality than other antiviral agents tested in the trial. However, it showed promising activity against SARS and MERS in experimental animal models. A recent in vitro study of remdesivir demonstrated its potential activity against SARS-CoV-2 SARS-CoV-2 in human cells by inhibiting viral replication post-entry. Additionally, case reports from China and Washington State indicate its promising activity for the treatment of COVID-19. There are at least 7 clinical trials currently evaluating remdesivir for the treatment of COVID-19, and it should be mentioned that this drug is not approved anywhere in the world and is not available for use in any patient at this time. Hydroxychloroquine sulfate is a less toxic derivative of chloroquine CQ. It was developed in 1946 as an anti-malarial agent. It's also used for the treatment of several autoimmune disorders, including systemic lupus erythematosus, SLE, and rheumatoid arthritis. In vitro studies in human cells indicate that hydroxychloroquine inhibits the SARS-CoV-2 receptor glycosylation, which appears to disrupt viral entry. Additionally, it inhibits the virus post-entry, possibly through the inhibition of endosomal acidification, which disrupts viral release. In an open-label, non-randomized clinical trial, a total of 42 hospitalized patients with confirmed COVID-19 were included in a study. A total of 26 patients were treated with hydroxychloroquine and 16 patients served as control. 6 patients were dropped from the hydroxychloroquine only arm due to transfer to ICU, and 1 patient died 3 days post-inclusion. On day 6, 70% of the patients who received hydroxychloroquine were virologically cured, and that's a term used by the authors in the paper, and I suggest if you're interested in that, check out the paper for the definition of that, compared with 12.5% of patients in the control group. Patients who were treated with a combination of hydroxychloroquine and azithromycin were 100% cured, compared with 57.1% of patients who received hydroxychloroquine only. This diagram shows the percentage of patients with PCR-positive nasopharyngeal samples from inclusion to day 6 post-inclusion in COVID-19 patients treated with hydroxychloroquine only, treated with hydroxychloroquine and azithromycin, the combination, and also in control patients. The results of this small clinical study are quite promising, but it's a small study. The authors suggest that hydroxychloroquine and azithromycin may have potential in the treatment of patients with COVID-19. Further investigation of the adverse events within the context of COVID-19 will be needed. There are currently at least 7 clinical trials that are investigating the efficacy of hydroxychloroquine for the treatment of COVID-19. A notable trial that was initiated recently by the University of Minnesota aims to evaluate hydroxychloroquine as a prophylactic agent for healthcare workers and those having contact with patients with COVID-19. The results of this trial, if demonstrating efficacy, will be very important in limiting the spread of the disease. Under the current circumstances, with the widespread extent of the disease, the convalescent sera could be a viable option for the prevention and treatment of COVID-19. Individuals who were infected with SARS-CoV-2 and recovered are a good source for convalescent sera. Previous results indicate that this strategy is more effective for prophylaxis than for treatment. This strategy was used successfully during outbreaks of other viruses such as H1N1, Ebola, and SARS. Several measures are needed for the successful application of this therapeutic strategy, including the availability of donors, blood banking facilities, serological assays to determine SARS-CoV-2 in serum, and virologic assays to assess viral neutralization. Regulatory oversight is also needed for the design of clinical trials to better assess the strategy. Anecdotal evidence and case reports from China and other countries suggest that it does have potential for COVID-19 prophylaxis and treatment. Again, further studies are needed and are underway. Okay, so next look at host-targeted agents. Based on the evolving understanding of COVID-19 pathogenesis, patients who progress to advanced disease stage may experience severe destruction and multi-organ failure due to hyperinflammation. At this stage, drugs that are targeted at suppressing the immune response may be helpful in rescuing patients. Importantly, proposed disease staging of patients with COVID-19 could guide therapeutic decisions. Stage 1 disease can be treated by managing symptoms. The availability of effective antiviral agents could prevent the progression, minimize contagiousness, and facilitate recovery. Patients with stage 2 disease might require hospitalization for the management of symptoms. Antiviral therapy could prevent progression and facilitate recovery. Patients with hypoxia need mechanical ventilation support. In stage 3, patients could benefit from immunomodulatory drugs such as IL-6R targeted monoclonal antibodies such as tocilizumab. SARS-CoV-2 infection of the upper and lower respiratory tract causes mild to severe acute respiratory syndrome. This condition is associated with the release of pro-inflammatory cytokines including interleukin-1 beta and IL-6. These effects could be mediated by the binding of SARS-CoV-2 to the toll-like receptor, TLR, which sustains lung inflammation, fever, and fibrosis. IL-6 is a key cytokine and an integral component of the immune response. Drugs that target the IL-6 receptor, such as tocilizumab, are approved for the treatment of rheumatoid arthritis and juvenile inflammatory arthritis. Similarly, targeting the IL-6 receptor to suppress the hyperinflammatory condition associated with SARS-CoV-2 infection could be an attractive strategy for the treatment of patients with advanced stage COVID-19. In this small-scale clinical study that was conducted in China, 21 patients with severe COVID-19 diagnosis were enrolled. The patients received tocilizumab 400 milligrams once daily via intravenous drip. The authors reported that all patients had lower body temperature after 1 day of treatment. Additionally, oxygen saturation was improved and markers of inflammation were significantly reduced. The lung opacities on CT scans were improved in 19 patients. No adverse drug reactions or subsequent pulmonary infections were observed during the study. The images show the improvement in lung images in 3 patients within 5 days of treatment. This is a small observational study. A randomized clinical trial investigation is still needed to further confirm the efficacy of this approach. There are currently at least 3 ongoing trials that aim at evaluating the efficacy of IL-6R inhibitors, tocilizumab and sarilumab in patients with COVID-19 are being evaluated. And I just wanted to point out this is being recorded at the end of March 2020, so these studies will be updated probably by the time you watch this presentation. Just be aware of that. Alright, what is on the horizon for the treatment of COVID-19? In a recent study by Hoffman and colleagues, potential therapeutic targets for SARS-CoV and SARS-CoV-2 were identified. SARS-CoV-2 infection is dependent on the host cell factors ACE2 and protease activity of TMPRSS2. Priming of coronavirus S proteins by host cell proteases is required for viral entry into cells. This process involves the cleavage of S protein by TMPRSS2. The serine protease inhibitor camastat mesylate, which blocks TMPRSS2 activity, is approved for another indication in Japan. This compound could be considered for evaluation for the potential treatment of COVID-19. Additionally, antibodies that target the spike proteins could be attractive for the prophylaxis and treatment of COVID-19. SARS-CoV-2 main protease. The SARS-CoV-2 main protease is an attractive pharmacological target for a potential treatment. It plays a key role in processing the polyproteins that are translated from the viral RNA. Inhibition of this enzyme would block viral replication with a minimal expected toxicity. Based on the crystal structure of this key target, a lead compound was developed. The pharmacokinetic analysis of this compound indicates the possibility of administering this agent by inhalation for the treatment of COVID-19 patients. For all the details on this study, please check out the article by Zhang and colleagues in Science. Again, just a reminder, when you watch this, new findings may have emerged that supersede what has been presented here. Let's all hope that there is an effective and safe treatment for all stages of this disease, and hopefully for the prophylaxis of the healthcare workers that are putting their lives on the line to treat patients with this disease. None of this presentation is meant to be construed as medical advice, and if you're a patient, please consult obviously with your healthcare professional. If you are a healthcare professional, please follow guidelines and all the regulations put out by the FDA. Thank you so much for watching this. We have several available courses on this platform. Please check them out at nascentmc.com/coronavirus courses. Coronavirus-courses. It is up on the top of the Nascent MC page. Thanks again. To start, we will cover some of the recently publicized topics related to drug contraindications and drug-drug interactions, with perhaps the most attention paid to the use of non-steroidal anti-inflammatory drugs, or NSAIDs. On March 11, 2020, The Lancet published a letter concerning the link between angiotensin-converting enzyme 2, or ACE2, the expression of which is increased with ACE inhibitor use and with ibuprofen use. This letter spurred a series of news reports and also a tweet from the French health minister about the possibility of NSAID aggravation of COVID-19, recommending the use of acetaminophen instead. By March 19th, the U.S. FDA stated that as of that point in time, there was no evidence supporting an association between NSAID use and COVID-19 symptom aggravation. The CDC has also stated that there is currently no evidence that COVID-19 patient outcome is affected by NSAID use. The WHO initially recommended against ibuprofen use, but then reversed its position. However, in a review of contraindicated medications with respect to patients with metabolic diseases, the authors concluded that ibuprofen and other NSAID avoidance was reasonable and to select acetaminophen instead. Unlike the postulation and position reversal accompanying NSAID use, there seems to have been a consistent agreement on avoidance of corticosteroids in the Western press, despite their use in China at the pandemic's outset. The CDC recommends against the use of corticosteroids in the treatment of COVID-19, except in patients with COPD and other diseases indicating their use, and despite their wide use in China. The CDC has based this recommendation on the effect on patient outcomes that steroid use reportedly had during the SARS and MERS epidemics, wherein use of steroids was associated with higher ventilation requirement rates, prolonged periods of viral replication, and greater fatality rates. The World Health Organization mirrors this with a recommendation to avoid corticosteroid use in patients with COVID-19 unless there are comorbidities such as COPD, asthma, or septic shock. For patients in septic shock, corticosteroids can be weighed in the particular patient against the potential for prolonged viral replication. The World Health Organization recommends that patients with COVID-19 and septic shock who are treated with steroids be monitored for hypokalemia, hyponatremia, and hyperglycemia. Hydroxychloroquine has also been subject to controversy in COVID-19. The antiviral and anti-inflammatory properties of chloroquine have been established, which prompted its and also hydroxychloroquine's implementation in COVID-19 management. Preliminary studies were promising, one of which included a study that demonstrated that hydroxychloroquine significantly reduced viral load in patients with COVID-19 and was more effective when combined with azithromycin. However, subsequent to the publishing of this study, the International Society of Antimicrobial Chemotherapy issued a statement expressing concern about the standards to which the Society's journal was held. The president of the ISAC stated that The ISAC board believes the article does not meet the Society's expected standard, especially relating to the lack of better explanations of the inclusion criteria and the triage of patients to ensure patient safety. Hydroxychloroquine and chloroquine are considered under investigation as per the CDC's website at the time of this recording, which is mid-April 2020, although they list all drugs, antivirals, antimicrobials, as under investigation since no drugs have been approved for use in patients with COVID-19, except for oxygen supplementation and mechanical ventilation. However, it has been established that chloroquine, hydroxychloroquine, and azithromycin prolong QT interval. Prolonged QT interval when drug-induced is associated with torsade de pointe, a potentially lethal ventricular arrhythmia. However, not all drugs that prolong QT interval are associated with arrhythmogenic deaths have been reported in relation to chloroquine use during WHO's surveillance so far. Patients with COVID-19 are more likely to have baseline prolonged QT and arrhythmia because of the infection. However, the benefit of chloroquine and azithromycin use may outweigh the risk of arrhythmia, and the American College of Cardiology recommends that patients at greater risk of arrhythmia be identified for the implementation of preventive countermeasures. The ACC recommends that at baseline, other QT prolonging medications that are non-essential should be discontinued, and an ECG along with renal and hepatic function tests and serum potassium and magnesium levels be assessed. It's also recommended that a cardiologist or electrophysiologist evaluate the QT interval and a pharmacist be consulted where there is renal or hepatic failure. Contraindications that may still need to be considered in the context of COVID-19 risk include a long QT syndrome history and or a baseline QT interval of greater than 500 milliseconds, or where QRS is greater than 120 milliseconds, a QT interval of greater than 530 to 550 milliseconds. Telemetry should be started prior to therapy. Daily monitoring and appropriate adjustment of serum potassium should also be implemented. Following the second dose of hydroxychloroquine, an ECG should be obtained and repeated daily. Parameters of azithromycin discontinuance and decreased hydroxychloroquine dose include a QT interval increase of more than 60 milliseconds, or an absolute QT interval of greater than 500 milliseconds or greater than 530 to 550 milliseconds, where the QRS wave is greater than 120 milliseconds. Parameters of hydroxychloroquine discontinuance include a continually increased QT interval of greater than 60 milliseconds, and as listed on the screen, if these criteria are met, an electrophysiologist should weigh in on the benefits and risks of continued chloroquine therapy. For stabilized patients, the risk of outpatient ECG with respect to viral transmission, i.e. to others, should be weighed against the risk of either foregoing monitoring or alternative forms of outpatient ECG monitoring. Where a patient has a Tisdale risk score of less than or equal to 6, medications prolonging QT may be considered without ECG or telemetry assessment where these are unavailable. Where PPE resources are limited, ECGs can be obtained in a clustered manner 2 to 4 hours following medication dosing. Surrogate equipment for 12-lead ECG evaluation can be used, such as telemetry, and as can mobile devices such as the Apple Watch 1 lead, KardioMobile 1 and 6 leads, iRhythm, Preventis, or BioTel. The question has been raised as to whether angiotensin-converting enzyme inhibitors, ACEIs, or angiotensin receptor blockers, or ARBs, might increase the risk of COVID-19 infection and or severity. This is because both classes of therapy promote the expression of angiotensin-converting enzyme 2, which is the means of viral entry into the cell. However, there has been no evidence to support this, and the American Heart Association, ACC, and the Heart Failure Society of America have all issued recommendations for continuing these therapies where indicated for patients with cardiac disease. Assessments of COVID-19 therapies in patients with diabetes or other metabolic disease reflect much of what has been discussed with respect to cardiovascular disease patient medications. One review of pharmacotherapeutics, diabetes, and other metabolic syndromes with COVID-19 management advised that it is not possible to make recommendations for chloroquine based on the data thus far. The review advised that hydroxychloroquine could be used off-label in patients with moderate to severe infection. The data from Wuhan do not report any significant difference in survival between those treated with ACE inhibitors and ARBs compared to those who were not. The European Society of Cardiology Council on Hypertension, European Society of Hypertension, and the AHA have all recommended the continuation of these therapies where indicated. With respect to cancer therapeutics, no current evidence suggests that TNF-alpha inhibition should be contraindicated in patients with COVID-19. Furthermore, a literature review found no evidence to support the contraindication of cytotoxic therapies, low-dose methotrexate, anti-TNF-alpha agents, NSAIDs, or JAK inhibitors. An article in Headache reviewed medical therapies used for migraine in the context of COVID-19. The article cited WHO's reverse position on NSAIDs and advised that clinicians consider NSAID use on an individual patient basis, but reflected the American Headache Society's 2015 support of NSAIDs, triptan, and antiemetic use for acute migraine treatment. With respect to the CDC's recommendation against steroid use, the authors of the Headache article advised that a taper for immunocompetent patients should be considered, again, depending on the individual patient needs. The authors also suggested that alternatives to onabotulinum toxin A be considered for patients managed with this therapy, since it requires close contact between patient and provider. The topic of ACE-IS and ARBs was again raised with respect to candesartan and lisinopril, which have shown some efficacy in migraine treatment. And again, the ACA, AHA, and HFSA were referenced in the author's discussion of considering individual patient needs in light of the raised hypothetical risks of ACE-IS and ARBs. A review of the pathophysiology of COVID-19 in pregnant women, which appeared in the American Journal of Obstetrics and Gynecology, agreed with the WHO recommendation to avoid corticosteroid use in infected pregnant women, not because hydrocortisone and methylprednisolone cross the placenta easily, but because of the risk of prolonged time to viral clearance and increased risk of hyperglycemia, which is immunosuppressive and can prolong the viral replication period in the mother. However, exception is made wherein fetal maturity is desired for preterm delivery when medically necessary, at which point corticosteroid use can be considered on an individual patient basis, with the goal remaining best practices in obstetrics. Chloroquine phosphate crosses the placenta but has been assessed as safe to use in all pregnancy trimesters, although studies have shown significantly decreased plasma levels of the drug during pregnancy, which suggests an increased dosing that may be necessary. Clinicians should bear in mind that chloroquine can induce systolic hypertension, which could aggravate the hemodynamics resulting from a gravid uterus. Antiviral remdesivir has been shown to inhibit SARS-CoV-2 replication in vitro and is apparently safe for use during pregnancy. Phase 3 trials investigating remdesivir are underway in China and the US. Protease inhibitors lopinavir and ritonavir have demonstrated some effect in COVID-19 management and are considered safe based on a surveillance of use in HIV-positive pregnancies, which reported no adverse effects. Ribavirin, on the other hand, is a known teratogen and as such is contraindicated during pregnancy. Similarly, the Janus kinase inhibitor baricitinib that is being investigated in the management of COVID-19 has been associated with embryotoxicity in non-human animal studies and is contraindicated in human pregnancy. Meanwhile, currently investigated vaccine mRNA-1273 has an unknown safety profile in pregnancy. Aggressive fluid therapy may be contraindicated and should be closely monitored in children and adults with a severe acute respiratory infection, as it may depress oxygenation. Conservative fluid therapy is also recommended for patients with acute respiratory distress syndrome in the absence of tissue hyperfusion. The University of Liverpool has compiled an updated online chart of potential drug-drug interactions with respect to the investigational medications used to treat patients with COVID-19. Drugs in this chart have been grouped by class. So, for example, one of the first classes covered is analgesics, which are color-coded by their potential for interaction upon co-administration with any of 9 investigational COVID-19 therapies that include azithromycin, lopinavir, ritonavir, remdesivir, favipiravir, chloroquine, hydroxychloroquine, ribavirin, and tocilizumab, and interferon beta. Single-line arrows are used to indicate increased or decreased exposure to medications, and double-lined arrows indicate the potential for increased or decreased exposure to the COVID-19 medication. The red color code in the analgesics chart indicates drugs that are advised not to be co-administered with antiviral agents atazanavir or lopinavir ritonavir, and includes dextropropoxyphene. Metamizole is listed as contraindicated with chloroquine, hydroxychloroquine, ribavirin, tocilizumab, and interferon beta. Reflecting some of the concerns expressed by the American College of Cardiology, the University of Liverpool drug interaction chart lists several antiarrhythmics as contraindicated in co-administration with atazanavir, lopinavir, ritonavir, and/or chloroquine or hydroxychloroquine. These antiarrhythmics include amiodarone, beprudil, and others listed on the screen. As another example, there are several antibacterial agents that have been categorized into the potential for drug-drug interaction, with rifampicin designated as contraindicated with atazanavir, lopinavir, ritonavir, remdesivir, chloroquine, and hydroxychloroquine. Please do go check out our COVID-19 Resource Center, which is available at nascentmc.com. In the top menu bar, it says COVID-19 Resource Center. Click on that and it'll take you to several courses at a wide range of different topics available. Thanks much.